was a 10-year-old who I presented several months ago, 10-year-old who regularly sees our counselor here in our social worker here in our school health center, who has autism spectrum disorder, OCD, and was having a lot of anxiety. And that was one of the reasons for the original consultation, was to try to help get a handle on the anxiety and the OCD. And if you are able to see the case form, you can see, you know, the original story and the original recommendations. Part of that recommendation was to start him on an SSRI, and we did that. We put him on Celexa. We started 10 milligrams. And he comes in with his mother or his grandmother, and both the parents and the grandmother and the social worker here really think that his anxiety has improved a lot since starting on the Celexa 10 milligrams. He just seems less anxious. He's doing less self-stimulating behaviors like finger snapping. He's still struggling with some OCD, and I gave the example in my case form of that he only wears one pair of glasses, one particular pair of glasses that he trusts because he thinks the other ones are somehow monitoring him. I think it's not like a schizophrenic type paranoia, but it's more than just not liking the style of the glasses. But when I saw them recently, the mom said he's doing much better. She said he still has several days every so often where he is just freaked out. And the day that I saw him most recently was about 2 weeks ago, and he had 3 days the previous week where he was just freaked out from the minute he got up, and they let him stay home, and eventually he got through it. He himself is interesting. He doesn't really, he says he doesn't feel that different. He says he feels fine. When I asked him about those freak out days, he said, well, I mean, on one of those days, I remember I just couldn't get my hair right. And, you know, it got me really upset. And so they just kind of roll with that when that happens. So overall, we think he's doing much better with respect to the anxiety. He's also doing really well in his therapy sessions, and she's working with him on the OCD, and feels, she couldn't be on the call today, but it feels like he's making really good progress. So my questions are actually related to several things the mom brought up. She, of course, had heard from several people, several things that she was worried about that made her worry with the Celexa. One is what's the long-term safety in children? And she couldn't really describe this, but she heard that there were some adverse sexual side effects in the long term. I think that people who are talking to her may be sort of conflating known side effects in adults with long-term safety in children, but she couldn't even remember what they said, just that there were sexual side effects in the long term. And my next question is, again, related to a question the mom asked, that she heard Prozac was better. And from our previous echo session, I think I started the Celexa because it was recommended, and I'm not aware of SSRIs having a difference in treating OCD. She was talking about, not anxiety, but I wanted to double check myself on that. Is there one that's better than another? And I've been saying that I had him on 10 milligrams. I started him on 10 and then increased him to 20. So he's been currently on 20 for probably about 6 weeks, maybe 2 months. And, you know, we thought about increasing him to 30 milligrams per day, just because of these, you know, these residual episodes where he gets her anxious. But both the mom and I, and also the social worker, kind of reluctant to do that. For one thing, the mom kind of has a hard time, other than those very dramatic days where he gets very anxious. She has a hard time pinpointing any other symptoms, or knowing how she would know if he's improved. And she's a little bit reluctant to increase. We're all a little bit reluctant because he seems to just be doing really well. And so I'm not even sure how we would be monitoring or measuring if we increased to 30 milligrams a day, other than perhaps less frequent of those severe episodes. And those episodes that occur that I described, they may be more related to the OCD than the anxiety, and I know they're probably interrelated, but the social worker here taught the family and then taught me this term OCD storm. That's what she has described it as, and so I'm not sure that increasing would help with that. So those are my questions.
Thank you so much, Jennifer, for that follow-up case and the questions. I wanted to ask everyone out there on the Zoom call if there were any comments or questions about that. Feel free to chat us as well if there are any comments or questions you guys think of. Perhaps if you had any similar cases. Did you guys have any comments or questions or recommendations?
So I guess I'm a huge fan of OCD in kids. To talk about this case, first of all, I missed your initial presentation of it, but it sounds like dramatic improvements of just amazing from where he was, and so definitely on the right track in terms of treatment. Diagnosis sounds right. All the interventions sound okay. I always like to sort of talk about, since there are some questions about the medicine, in the world of little kids, I think there's sometimes confusion between what is technically FDA recommended and then sort of things that may still have evidence base. And so from the perspective of having evidence base, Celexa absolutely has an evidence base. Actually, all SSRIs do have evidence base for OCD in pediatrics. However, 4 of them sort of add that additional layer of being FDA indicated. So the 4 that have the FDA indication, which may be why sometimes, which may mean there's extra studies, but that certainly doesn't mean that there isn't evidence, is Prozac, Zoloft, clonipramine, which is an old school tricyclic antidepressant, and Luvox, which we don't see used as much anymore. But Celexa is certainly appropriate. Actually, many of the long-term studies in OCD with kids were actually done on Celexa, even though it didn't have the FDA warning, even out to 2 or 3 years. And generally, they're considered really pretty safe medicines. When thinking about anxiety disorders, they're incredibly impairing, and a lot of times there's really high rates of relapse. So we always have to balance sort of our fear of risks from the reality that the illness can relapse. And as dysfunctional as this young man was from how severe he was ill, I think you are well justified in continuing it indefinitely. And if people have stabilized on an SSRI for OCD and have had really good interventions, we usually never urge people to stop it unless they've been on it for 2 years, because that relapse rate is so high that it can come back. So I think it's really important, at least until some of that additional skill building and success continues, that it be maintained. I guess in terms of the sexual side effects, that probably is referencing adults. It's completely reversible in adults. If you stop it, it goes away. There's nothing permanent about that. And specifically, the side effect is suppression of orgasm, where people feel like it takes longer to experience orgasm and there's a delay. Sometimes those are used therapeutically in people that feel like they orgasm too quickly. So certainly in a non-sexually active prepubescent child, I think that is probably very far down on my concern list, and certainly in the future, if that became a problem, there's actually ways to treat it, and it would completely go away. Probably the only real concerning safety data from long-term SSRI use is that there may be some increased risk of osteoporosis because it may interfere a little bit with bone growth. That's not a super severe risk and not been super established, but I always, in kids that are kind of into 2 or 3 years of SSRI treatment, I do a little added, like how much milk do you drink, how much calcium's in your diet, kind of thing. I think there might be some questions coming through, so I'll pause to see what's coming up.
Thank you. Jennifer, did that answer some of the follow-up questions that you had?
I did have one. Yes, it did. I have one question about the relapse. You're talking about relapse if they go off the medication, yes, right? Not relapse. Okay, on the medication. Okay, good. And then there was that one last question, Mitra, about higher dose. Is there any benefit of trying him on a higher dose, or should we just stick with what's working?
So when you think about the 2 anxiety disorders, panic disorder and OCD, those are the 2 anxiety disorders that really do justify going to higher doses. When you look at pediatric studies that have looked at dosing, and I see that someone called in with a POT study question. So the POT study was a pediatric OCD trial study that used Zoloft in it for treatment of OCD. The average dose range was 137.5 milligrams. And so if you think about dosing of Zoloft from 50 milligrams to 200, the 137 is definitely on the higher end. That's true for all SSRIs. So if you're looking at something like Celexa with the dose range being 10 to 60 milligrams, most of the evidence for OCD lies somewhere in getting it 30 to 60. So I think you're totally justified in going up. What you may be seeing with improvements, because I know he's had so much success, but a lot of times if you're seeing that transitional kind of anxiety and some of that perfectionistic tendencies, anything where there's like an element of obsessive control or an element of having trouble getting unstuck, that's still often sort of thought to be benefited from continuing the dose increase. Certainly, it's worth trying for 6 weeks, I think, to see if you get additional improvement. If no one can see any improvement, certainly lower it back. But I think you're well within the range of trying to change that. And some of those big like OCD storms are kind of like behavioral explosions that sometimes occur because people are so stuck they can't like transition out, and it just spins and spirals. And so if that's sort of at the root of some of the big explosive episodes, I think it definitely is worth trying.
Oh, that's great. That's very helpful. Thank you very much.
The Prozac dosing for OCD is usually about 30 to 60, and Luvox can go all the way up to like 200 or more. So there, as I said, you have lots of room.
Great. I really appreciate the guidance. Thank you so much.
Welcome.
All right. Were there any other comments or questions out there? Is there anything else you guys wanted to add? All right. Thank you so much, Jennifer, for that case. I'm really happy we were able to do the follow-up case. It's always interesting seeing, you know, a patient who was presented in a previous echo session. So did that answer everything for you, Jennifer?
It did. That was really helpful. I appreciate it.
All right, perfect. Well, thank you so much for that. And if you're ready, I can pull up your didactic for you. If you'd like, you can have the
just push down here. Okay. Yeah. Well, thank you for having me talk to you today. I know this may seem like a little bit of an unusual topic to talk about psychiatry, because sometimes we think we have such other bigger problems to occur, but this has become quite a deep passion of mine. And I recently, a couple of years ago, got involved in tobacco treatment training, and actually, surprisingly or not, I think it made me a much better psychiatrist. And I have learned so much about things I was not doing correctly, and I guess probably in self-disclosure, the biggest thing I was doing incorrectly was assuming that if patients were stressed out or depressed, that was not the time to address their tobacco use because they needed a coping skill to hang on to. And I have learned how misguided I was about that, and I've really implemented this with pediatric patients and adult patients with really good success. And so I wanted to share with you some principles from that to kind of guide you. I also, this is the course that if anyone is interested, WVU is giving, it's a 3-day course. Amanda took it last year, but you have the ability to become a certified tobacco treatment specialist, which is an international certification recognizing evidence-based practice. And we cover a lot of specialty areas like mothers that smoke and patients with mental health issues as well. So if you're interested in more, I would urge you to consider this. It's almost 24 hours of continuing education and is available on the WVU continuing education website. So we're going to talk a little bit about tobacco use. I think many of you are also probably seeing large amounts of vaping and e-cigarette use, which really impacts our patients. And to just give you some additional guidance for psychopharmacology in a mental health population. So this actually is true. Again, even patients with comorbid other substance use disorders or active depression, many want to quit, they just don't know how. And some of those same biases I had are often shared by our patients, that I couldn't possibly quit smoking. I'm too anxious or depressed. I'm using it to help me feel better. And the evidence doesn't really bear out about that, but that smokers actually do want to quit, and that quitting tobacco actually can improve their overall health and mental health. And some sad statistics I've learned along the way, and is the number of cigarettes sold in the United States. Over half of them are consumed by patients with mental health disorders, and patients with mental health disorders are more likely to be higher nicotine users and some of the more highly addicted patients that we have. And strategies to help them may be different because their dependency is so much higher. It's also incredibly rewarding to help them not smoke because they save thousands of dollars a year, which they can funnel into other things that they enjoy. And so it's really helpful to feel more successful at being able to do this other than just tell someone to quit. So a couple of things that were different for me is we always sort of used to ask, do you smoke? How many packs a day you smoke? But kind of a really important sort of tidbit to remember in helping people with the pharmacology is you have to know the exact milligrams that they're using of nicotine to really get their coverage. And this kind of goes back to the philosophy of if a patient's in withdrawal or craving, they're kind of functioning in like a fear flight sort of mode where they can't participate or listen. And you have to really help contain the withdrawal and help them stay grounded so that they can do the harder work of cessation. And so in order to cover the severity of the nicotine cravings, you have to make sure you cover it accurately. And so you have to know what they use, what form they use. And I've certainly discovered this with adolescents. I'm not sure if you've seen this with adults, but if I just ask if people smoke, I almost get a no if they use smokeless or electronic cigarettes. Or vaping, you really have to ask specifically about chew and smokeless tobacco and vaping, or people will say no sometimes to cigarettes. The other truth is that most of the time people are using multiple products, and even people that may start using vaping products will likely go on to use cigarettes or other forms of nicotine as well. So in terms of strict milligram conversion, just a basic sort of rule, 1 pack of cigarettes has 20 milligrams of nicotine because it has about 20 cigarettes in it. This is slightly variable, but that's a good way to sort of ballpark how much nicotine's in cigarettes. If people are using cigars, you have to kind of know what the size of the cigar is, but essentially 1 large cigar is about equal to a pack of cigarettes, which again would be about 20 milligrams. Some of the small ones also have very, very large quantities of nicotine in it. And as you see, that cigarillo says 3 grams, not milligrams. That's a lot of nicotine. Little cigars are about the same as 1 cigarette, so that's a direct conversion. In Morgantown, we have a lot of people we have a hookah bar. People frequently use hookah. Actually, an hour of smoking on a hookah also links to a pack of cigarettes. This is really important in West Virginia. We are by far the highest use of smokeless tobacco in the entire country. The percentage use of our white male population is almost 16%. That is really concerning. The nationwide average of smokeless is only about 3%. And so we have 16% of our male population using smokeless, and we forget to ask about that. And smokeless products have been super engineered to pack in very large quantities of nicotine. They can manipulate the pH and add more to it. And so people find themselves using very high qualities. So you have to ask how much of a can they use. Copenhagen and Grizzly, which are 2 of the most highly marketed products in the state of West Virginia, and they make a fortune off our state. 1 can of Copenhagen is 80 milligrams, which is 4 packs of cigarettes. And so we have a lot of patients with smokeless tobacco use that can't get off nicotine products because they are using so much more than people realize. That traditional cessation methods don't really help them, and we have to kind of think outside of the box about how to get them covered. So just a quick little background on sort of vaping and e-cigarettes. They also are being highly evolved in terms of their production and manufacturing. These are the traditional ones that came out. These are these are electronic cigarettes. The key components of any type of vaping or electronic cigarette product is you have to have a power source or a battery that has to heat up and charge so that it vaporizes the substance. So as we progress through these, you'll see that the products become bigger, bolder, and more powerful to deliver nicotine. And they've also become very engineered in that people have been able to change pH to make them more tolerable. So if you think about if you've ever smoked a cigarette and you are totally naive to it, it's hard to get through a whole pack the first time because it kind of burns and it kind of can be a little bit uncomfortable until you're used to it. With some of these engineered products, you don't get the burn, and so people get up to very high levels of use very quickly. The second generations were your tanks. These have bigger batteries and started introducing the concept that people can mix flavorings or their own flat flavors in. They could make their own juice. We've also seen people introduce other substances other than nicotine into these products. We kind of make your own, like marijuana or cocaine can get inserted into these. The third generation mods, again, just see how big those batteries are. They're just getting bigger and more customizable in terms of how they look. And then we started having sort of larger system deliveries things. I'm sure you're all familiar with the Juul. We now are seeing things called Sorens or Fix or IQOS. All kind of sound very cool, but these are sort of these are kind of developed mods by manufacturers that can be sort of immediately delivered. You don't have to customize them as much. These are a little bit easier to calculate milligrams because they're very set amounts usually in terms of their products. When you're working with somebody that's using e-cigs or some of the customizable mods, it's really hard sometimes to figure out how many milligrams they're using. But this, again, just gives you a sense of how powerful these things are. Again, we have the base of 20 cigarettes in a pack of cigarettes. A 1 Juul pod, that's the 5.9% concentrated. 1 pod is already 2 packs, almost 41 cigarettes. And we are seeing, I have many kids that are using already up to a pod a day, and they really can't stop. The Fix is almost 75 cigarettes per cartridge, and the Soren is up to 90. So these are 90 milligrams delivered in 1 pod. So you have to ask patients how much they're using, which product they're using. At the end of the day, you're trying to add up what their daily milligram amount is to appropriately cover for just nicotine replacement therapy. The reason it's important to sort of think about pharmacotherapy is that if we just, and it's really important that we tell people as healthcare providers that the best thing that you can do for your health right now is to quit, and how can we help you. If we don't offer additional assistance, the chance that they'll have success is only about 3 to 6%. And if we don't provide support, people get frustrated. You see lots of people trying to quit, and they kind of set themselves up for failure because they haven't been given all the supports that they need. And I think this leads to frustration on patients' part, but it was also very frustrating as a provider, because I was trying to encourage people to stop, but I wasn't providing the right way for them to do it. And so I was getting burnout at people not being successful either. And learning this has really helped me feel more successful with my attempts to help people quit. So these are really complicated charts, and you can kind of see what the rate is. The short version is in the far right column there, is that with at least one monotherapy attempt, we can get sort of quit rates up to around 25 to 30%, which is far better than 3 to 6%. The top one at that list is Varenicline, where you see that single trial agents of Varenicline, which is Chantix, can get success rates up to 33%. That may not seem like it's huge, but if 1 in 3 smokers quit, we would save millions upon billions of dollars to our healthcare system. Every dollar that we invest in cessation saves us $2 in the long run. So 33% is actually huge. The American Academy of Cardiology came out with recommendations in 2018 that said for all patients, you should either pick Chantix or a combination of NRT as your first line treatment. And I'll be talking a little bit about the NRT a little bit, but the NRT is a combination treatment that usually involves the patch with an ad-lib add-on like gum or lozenge. So that's what I'll show you in the next rate. But these are the success rates from various agents, and then the next slide is going to be on combination. You see Varenicline topping the list on monotherapy. And then here's the combination, where if you have patch and either gum, spray, or lozenge, you can get up to 36%. And I just want to say this is first line. These are not, this isn't like second or third line. And I think the hope that you can deliver to patients is if you have a successful trial at first line that fails, we can really move on to more combinations and other strategies to really help people. So this is really your first out of the gate 1 or 2 option. Okay. Now the important thing about the NRT is to dose it correctly. Most of the time, if you call and you don't really tell people how much you're using, everything related to NRT success is about covering the need. If you underdose someone with a patch, or they don't give themselves enough nicotine coverage to get out of that crisis craving mode, it's going to fail. So those strategies about knowing how many milligrams to cover really matter. Several of these products are also available over the counter. So the patch, the gum, and the lozenge are all available for people to walk in and purchase at any pharmacy. And so part of the tobacco treatment course is really empowering all healthcare professionals, especially non-prescribers, to really understand how to use correctly the over-the-counter products, because this leads to rapid access. In the state of West Virginia, there are some issues with people obtaining NRT. It is costly. Some insurance plans pay for it, some of them do not. But there's several options through the 1-800-QUIT line where people may have access to product or can have it delivered to them. But sometimes there's a time lag in getting that. It's also very important, if you've assessed somebody, to make sure you communicate the need and the milligram need, or they may be underdosed if they aren't being accurate about their use. The Chantix and the Zyban are both prescription medicines. The Zyban is the brand name for bupropion, which many of you in this echo will recognize also as the brand name of Wellbutrin. So it is the same medicine that we use for depression. I'm going to pause for a minute and see if there are any questions. I was going to go through sort of dosing and how to actually write these if people would like, and talk about some combination and special populations at the end. But how about I just pause and see if there are any questions so far?
This is Jennifer Boyd. Thank you for this presentation. It's great. When you're talking about this, could you let us know if what is approved in teens? Because that's my big question is about teens who are vaping. Am I allowed to give them nicotine replacements?
Yes, and actually the American Academy of Child and Pediatrics and the Pediatric Association suggests that kids cannot stop on their own. In fact, that level of use is so high that they're failing completely at stopping with just cold turkey. And so the call has been for pediatric patients to receive treatment. I will mention this again, but but there is evidence-based. None of this is off-label for smokeless and off-label for people under 18, but there is definite evidence-based for the patch, nicotine gum, and bupropion in adolescent patients to help them quit, and I use those things regularly. There's actually safety data on the Varenicline, meaning that they've done trials that have not shown adverse outcomes, but it's failed to be significant, I think, because they've not been able to retain people. But there's definitely safety and efficacy data for the patch, the ad-lib nicotine replacements, and the bupropion in teens, and we are using them regularly. So I'll highlight that a little bit more. They're, of course, all off-label, so you have to have conversations with people about that. They're actually, you have to kind of know this, but because it depends on who picks up the phone. But we have had conversations with the Quit line that they will pay for pediatric NRT replacement, but you usually have to sign as a provider that they're under your care, because they won't immediately give them product because it is off-label unless they have a provider willing to sort of say that they're writing it. And there's a form that they have to send you, which is a little bit different for you sometimes to sign off, but they are covering it. So that's an excellent question. The other real off-label issue is with pregnant patients. I think pregnant patients are actually a little bit more complicated than even adolescents, because whereas in a lot of things, you know, it's not the nicotine that causes the long-term health consequences. Nicotine is what's causing the addiction and why they keep using it, but often the long-term health consequences are related to the additives in the vape, or is related to the actual tobacco carcinogens. The problem with pregnant women is the nicotine probably does have an impact on the developing brain. To some degree, there's some frontal lobe effects of nicotine exposure. But even kind of getting pregnant women to quit really has long-term health benefits, because they're not maybe exposed to the combustibles. So they have started with pregnant patients urging you to really have conversations about risk-benefit for the patient. If a patient is smoking 4 packs a day, they're getting the same amount of nicotine that your patch would, but the patch may still offer benefit over the combustible exposure and the anoxia that may come to the infant. And so you really get into these very strong risk-benefit discussions with patients. So with pregnant patients, they do urge a little bit more safety concerns. They usually start with the ad-lib gum and lozenge, and then kind of more likely to consider the patch. The bupropion and the Chantix, because their prescriptions don't have as much safety data in pregnant women, bupropion used to carry a level C risk, which has all kind of gone out the window, but they fed it to, it used to cover a B. It's now a pregnancy C category, just to be in line with other antidepressants. But they used to feed large quantities of bupropion to rats that were pregnant without significant damage. But most of the evidence for pregnancy is the nicotine too, with a lot of motivational interviewing and psychotherapy support. So that's a really good question. Are there any other questions before we kind of move quickly through how to dose and prescribe it? Okay. So the 3 items on this screen, the patch, the gum, and the lozenge, are all available over the counter. The most common NRT combination is patch. And the patch takes a very long time to kick in. You put it on in the morning, it takes almost 6 hours to have the full effect, but then it helps cover throughout the day. You try to pick the strength of your patch equal to the amount of milligrams someone is smoking. So if you're a pack-a-day smoker, which is 20 milligrams, you would pick a 20 milligram patch. If you are a 2-pack-a-day smoker, the evidence would say you should pick 2 21 milligram patches up to 42 milligrams. This gets a little bit complicated as doses increase, and it's not recommended to go above 2 21 milligram patches, although you will hear stories about people that have gone 3, 4, and even 5 milligram patches based on the amount that they need. You have to make sure they're not getting nicotine toxic. The beauty of this is that patients are amazing at self-reporting their symptoms. They are experts at knowing how to dose it, and the thing that will happen if you don't cover them is they will smoke. We used to live in the land that if you smoke on a nicotine patch, you're going to have a heart attack. That's completely untrue. They're just trying to get their needs met so they don't go through withdrawal. So in addition to applying the patch, you give people a lot of education about using the gum or the lozenge. The gum and lozenge take anywhere from 30 to 60 minutes to kick in, so you have to educate people that it's not as fast as the cigarette. The cigarette is 7 to 10 seconds, and nothing is going to be that fast. And this is where sometimes counseling techniques help people kind of ride that crave until the nicotine kicks in. But the gum and the lozenge both come in 2 and 4 milligrams. You decide, there are 2 questions you can ask to decide which strength to give, and I will go through that with you on another slide. But okay. The patch is very well tolerated. Again, it's a very slow onset, but also helps to provide a little education. Most of the discomfort people have, they have a little bit of rash, they need to sort of move the site around. You can use a little hydrocortisone cream to help if there's irritation, to really help people kind of manage that. The starting doses, as you see here, if they're using anywhere from 21 to 39 packs per day, they're recommending, again, correcting the milligram strength for that. So you can see, and again, there's not a ton of evidence beyond the 42 milligrams, 2 patches. So we usually try to think about other combination strategies and people that might be using 80 to 100 milligrams a day. The gum, you have to tell people how to chew it. It's not like bubble gum. They have to chew, wait for the tingle, park it in their mouth, let the tingle go away, and then when the tingle's gone, you chomp it and park it again. This takes, maybe 15 to 30 minutes to kick in, so you have to sort of tell people to kind of wait. I think the biggest thing, you can use this every hour to 2 hours, and the biggest thing is people do not use enough coverage. They kind of get in their head this idea, oh, if you've ever dieted, oh, I'm going to be really, really good. I'm going to restrict, and then you're so hungry and so overwhelmed you binge. The same thing happens if you don't cover yourself. You tell people, if you're having an urge, use it. It's the best thing that you'll do from kind of blowing it at the end of the day. So some of the biggest things I notice with patients is they never given themselves enough nicotine to cover their need, and they're very reluctant without coaching to use enough of the NRT. So these are the 2 big questions that help you decide which PRA or sort of ad lib dosing. If the patient says that I have to use within 30 minutes of wakening, I get out of bed, I have to use, or if they tell you they wake up in the middle of the night to smoke or use tobacco products, they're going to need a 4 milligram dose. If it takes longer than 30 minutes or they're using less than a pack a day, you can start with the 2 milligram dose. This can all be adjusted. It says in there a little bit about timeline, and I'll make sure I mention that later, but there used to be this idea that you had to start tapering at like 6 to 12 weeks. That may be reasonable. It takes about 6 full months to see sustained behavioral change, and so for some patients, they may need permission to stay on it for 6 months before they try to cut it back so quickly. And I think sometimes our patients with mental health issues that have multiple issues, I'm going to probably encourage them to stay on as much as they need until I maybe address other things like depression or anxiety alongside their use. The lozenge is very similar. I think we talk more about the gum than the lozenge, but the lozenge has some very nice advantages. A lot of patients that use smokeless like the feel of that sort of pouch-like feeling in their cheek. The lozenge sort of sometimes replicates that a little bit better. And we have a very high toothless population of edentulous patients that don't have teeth, and so they can't really use gum. And so a lozenge is a very nice alternative. And the same rules apply to the 2 and 4 milligrams. How quickly do you smoke when you wake up, and what's your total use? Okay. And the idea is that between what you cover on the patch and the ad lib use every 1 to 2 hours throughout the day, we'll let the patient have some flexibility in covering themselves, so that the first step is to stabilize the total amount of nicotine a day for their need. And then you really deliver sort of the therapy and other sort of skills to kind of work on a plan when they're ready to kind of cut back and taper. There are 2 other nicotine products. There's a nicotine spray and a nicotine inhaler. Inhaler looks like a little puffer that people sort of like the tactile feel of. It unfortunately has really bad delivery. You have to like puff it 80 times an hour to even get the same amount of the gum, and most people are more just using it for tactile things. It's also fairly expensive. The nicotine spray is really fast, and there's certainly some areas where I would love to have nicotine spray. I have patients inpatient in the hospital that are like threatening to leave because they just so desperately need a cigarette. I kind of wish we could spray it up their nose because it works much, much faster. The problem is each bottle of the nicotine spray is over $400, so this is almost completely unreasonable for anybody to access. So you don't see either one of those used very much. Then there are 2 prescription products. As I said, the Varenicline is used as a monotherapy agent. Bupropion can be used as a monotherapy agent. But all of these medicines can be combined with one another. You can, even in people that have failed multiple levels of dosing, sometimes even varenicline is combined with bupropion, or they are both added to nicotine replacement therapies, and their algorithms for starting with this level of care and working through. Honestly, most of the time when I have patients tell me they have failed pharmacotherapy, when I go back and actually assess whether they had adequate trials, Varenicline is a lot easier to know if you had an adequate trial of, but most of the time people have not had adequate trials of the NRT because they were never, especially if they were high users using smokeless or vape, they never got enough milligram coverage, and so sometimes just starting there will get them better success. I'm not going to go over these, but they're there for you. Bupropion doesn't scare me at all because I use it for psychiatry, but I think this medicine is much more scarier for practitioners because it has so many more warnings on it, as you may know. It is trying to increase dopamine, which impacts the reward center, so that we're trying to help again with craving that is occurring. There's lots of warnings on this medicine, the same for psychiatry. It carries the black box warning for suicidality in patients 24 and under, which all antidepressants do. This is one you avoid in seizures or liver or kidney disease, and panic attacks, or people at risk for seizures. So people with substance use withdrawal problems, like at risk for alcohol withdrawal seizures, blood pressure problems, and then people that are purging that may have abnormalities are also kind of warnings. And so a lot of people see those warnings and they run away and go to other things, which is fine. But this is maybe a very nice choice in somebody with comorbid depression if they don't have those other warnings, because it can really help. And another population that really likes this medicine is that people that are very afraid of weight gain. There's about an 8 or 10 pound weight gain that comes from not smoking on average, because the nicotine is a stimulant. And so when that stimulant is gone, appetite is no longer suppressed, and there is some true weight gain increase that are reported. And this medication is used for weight loss and things like Contrave. And so people that are really afraid of weight gain, if they're healthy enough and don't have the comorbidities, can use this. The dosing, and this is the same for adolescents, this is one of the ones that has the adolescent data, is 150 milligrams once per day, day 1 through 3, and then day 4 through 7, you do 150 milligrams twice a day. It's important that the first dose be in the morning and the second dose be early afternoon. If you give the bupropion too close to sleep, you can have a lot more sleep problems. So I also have used just XL formulation once a day with some success. The XL formulation is much more expensive. The SR twice a day is actually really cheap. And for patients that have trouble with medicine cost, if I can put them on this, this is on the $4 list at Walmart. So this may be the cheapest option for some patients if they can't get it through their health insurance plan. You want to start this medicine before people quit. It takes a while to have the full effect, and so you don't want people to start it and expect, and they don't have to plan to quit, but they've even shown that some people that will start it will have less cravings for cigarettes. But you want to tell people it takes a week to start helping with cravings. It's important that this is much less than the therapeutic effect on depression that we often say needs 4 to 6 weeks. And again, there are some instructions. The Varenicline is also called Chantix. This medicine used to carry a box warning to avoid in psychiatric patients. It caused all kinds of, I think, fear. It also is very expensive, and it is going generic this year. So it may become more readily available. But the box warning about neuropsychiatric symptoms was completely removed in 2016. There was this giant, very well done study called the Eagle study that said all of those warnings about suicide and psychiatric worsening was absolutely untrue. This is something that still really exists in the literature and stigma for both providers and patients, and so that they sometimes don't know that has really been kind of changed. And so I think we're seeing more of it. I think we're getting more access to this as prescribers. I really struggled to get people on this. I did have a few pediatric patients that had failed bupropion and nicotine replacement. I tried to get them to approve Varenicline, and I failed miserably. So I was never successful in trying to get Varenicline approved for a pediatric patient in West Virginia. But again, no efficacy data, but there is safety data that they don't seem to have adverse outcomes. So you probably will see more of this being studied in the future for adolescents. The dosing on the Varenicline, and the nice part about the Varenicline dosing is if you can write it, they get this special little pack. So it's written out exactly for patients each day, like there's 1 pill or 2 pills, so that they know how to take it, which is also kind of convenient. On day 1 to 3, you take 0.5 milligrams once per day. Day 4 through 7, you take 0.5 milligrams twice per day, so 1 tab twice a day. And day 8 to the end of treatment is usually 1 milligram twice a day. Again, this is recommended that you start about a week before you see the effects. And there are some precautions on this, but honestly, this is one of the cleanest medicine that exists. Every psychiatric medicine I have has so many scary warnings. The Varenicline in comparison is so much easier. In fact, Varenicline, they're even advocating can be safely given to hospitalized patients with cardiac conditions and arrhythmias, because it seems to be much more preferential to treat the acuteness of their nicotine use for long-term health, and does not appear to carry other severe enough adverse outcomes. It also has a lot less drug-drug interactions than other things. Again, both of the prescription ones are kind of still considered no-nos in pregnant patients. Smokeless tobacco use is all off-label. None of these have been studied. However, you absolutely can use all the same things, because smokeless users tend to use much higher nicotine amounts. The difference with how you write for them is often they need higher doses of NRT, or they're more likely to need combination treatments, and that may be the patch plus Chantix, or the patch plus bupropion, or we even think we call it Chanban, where you combine Varenicline, the Chantix, with the Zyban, so Chanban and nicotine ad-lib. And so again, you have to work through those sort of protocols, but they often need dual therapy. I'm going to do a lecture on this, I think, next year, about actually how to do motivational interviewing, because I just find it an amazing skill for all things in my life, but really important. So I'm going to blow through that. I think we talked about specific populations. I'm sorry, we're very close to the end of time, but I would be happy to take more questions.
Thank you so much for that. Thanks. That's excellent. Yeah, were there any questions for Dr. Swiger about the didactic?
I have a question. The warning, though, for use of the Varenicline in people that have had suicidal attempts is still listed, and
No, that's the one that was removed in 2016. It's still on some of the old literature, but it was completely removed from new product labeling. That's exactly what the Eagle study removed.
even
So
on your slide, though, it said that use with caution.
Well, that was because of the warnings that were out there. Actually, some of that may not be specific to suicide. Probably the biggest complaint from Varenicline is actually sleep disruption. Some patients complain about vivid dreams that could certainly destabilize things, but it really has been removed. It's probably no different than any of the other ones. And if you look up the Eagle study, it's probably one of the best well-done studies I've seen. I think I have not seen anyone psychiatrically destabilized from Varenicline. I really try to use that one if I can, unless there really is things like Tagamet, some of the big 2D6 inhibitors you gotta be a little careful with and check the interactions. But I find that it's easier for patients sometimes to take the Varenicline than to keep up with the NRT. And I've struggled to get insurances to get enough NRT for some of my patients for milligrams. But if you really, and you know, we gave a lecture out in Maryland, and their tobacco quit line wouldn't let people go above 100, go above 21 milligrams a day. And so I think if you're in a situation where you can't get people enough NRT, you really do need to think about something like Varenicline, because they're more likely to have success as a single agent than a failed trial because they didn't get enough. So the reasons people haven't liked it is it didn't work, or as I said, the sleep's probably been the most common one. But from a psychiatric perspective, I've never once ever seen anyone destabilized from it, and those warnings have largely been very much minimized, if not removed. So I think you have to be careful with that. Anytime you introduce a medicine, I think I always think about, you know, is something changing with their illness? But
Well, thank you. That's good to know. I didn't know that. Thank you.
We also got a